Welcome to another episode of Cutting Edge Health. Today, we're talking about mid-back pain and why it is different from lower back pain. If we haven't met, I'm Dr. Orlando Landrum, an interventional pain and behavioral health specialist that helps patients understand how to be able to stop suffering, how to be able to punch pain in the face, and get back to leading the life that you deserve. Today, we're talking about back pain, and what we want to do is be able to kind of explain to you exactly what it is that you're dealing with. So when normally we talk about the mid-back, we're talking about the following. We're talking about the thoracic region. And in that thoracic region, one of the things that we can be able to kind of pick out is the area of the spine that exists in between the cervical spine and the lumbar spine, or kind of the neck and the low back, if you would. So when we take a look at that, one of the things that we can be able to kind of figure out and deduce is the following, is that there's a number of structures that are present there, right? So some of those structures, if we were to look at the back, directly from the back without focusing just on the spine alone, include the areas of the shoulder blades, as you can kind of see in this picture, or the scapula, which have their own challenges and issues that are associated with them. You have, if you were to take a look from the side, the ribs that are in place, having this curving component, these ribs play a major role in terms of how this portion of the back is different from the neck and from the low back. For those of you who are joining us, thank you again for joining us as always. And then when we get down to the nitty gritty, one of the things that we can see is the thoracic region has the most numerous number of vertebral bodies. And so when we talk about vertebral bodies, what we're talking about is these bones that exist to form the structure upon what is being really the stability of things are felt. So if we were to kind of take a look at this, the things that we would see as a vertebral body is kind of the following element. And that is this. So if we're taking a look, we can be able to see a vertebral body kind of out of plane. We can see the areas of the body. We can see the canal that exists and the various different structures that connect, right? So when we take a look at those structures that connect, one of the things that we want to be able to kind of have an identification of is, so how do those things impact what it is that we feel, what it is that we experience, right? And so when we are able to kind of ascertain and assess that, one of the things that we can see is the following, is that they interconnect through these different faces, also known as facet, F-A-C-E-T. And that facet is probably one of the premier structures for being associated with not only mobility, but stability. And that can be a major source of pain. So what we're looking at right now in this picture and cartoon, if you would, is the following. So if we were to kind of take a look and we were to look directly at a spine like so, what we're looking at is the areas of how the vertebral bodies sit over one another, separated by the disc, the nerves that come off of the spinal cord, and the facet joints that sit in the back, right? And so if we were to kind of take a look at that cartoon picture again, what we can see is that there's a distribution of weight and support, predominantly in the anterior aspect of the forward component bodies of the vertebral body and the disc, as you can see. That's what that functional unit happens to be. You can see the facet joint is what allows for mobility and has 30% of distribution. But because it's mobile and it's smaller, it's not as robust as that size of the vertebral body. So if you were to take a look again, so this is that vertebral body. Here you can see that area here. Then if we were to kind of turn that, you can see this facet that exists in the area right in here, right? And so those areas fit together in order to be able to formulate this mobile spine that allows for us to be able to move. The difference, though, and this is a major separation between the mid-back and low back, is those facets are oriented differently. In the mid-back, they're oriented differently in the neck or cervical spine, and they're oriented differently in the lumbar spine. And those things matter because how we treat them and what you feel is incredibly based on the orientation of those facets. So kind of giving you clarity about that, to kind of take a look at that with another sort of quick model, it would look like the following. So if we're to take a look at the neck, we can see these areas that are right there kind of in the side, right to behind the areas of the nerve root where you can see this bend that takes place. This is the cervical region. And as we progress into the areas that look a little bit further down, you can see these thoracic facets form kind of these scales, almost like an armadillo. And that makes for a much more challenging treatment. When we take a look at the lumbar spine, we can see that they form kind of these traditional sort of faces similar to what you'd have in a gemstone. And we've seen that normally represented across most pictures that look and evaluate and say, oh, this is a facet. But seldom is it talked about that when you look in the mid-back and the thoracic region, those facets, those angles, and the orientation changes drastically. So let's take a look at what that kind of pans out to when we take a look at another cartoon. You can see, again, you have this connection of the facet, these transverse processes that exist, the exiting nerve roots, and all these whole host of different things that exist. But one of the things that you can really be able to pick out is that there's also areas where the rib touches the bone. And that is a completely different area that can cause its own degree of pain. So if we're to take a look at a vertebral body, kind of looking down on it as we did initially, one of the things that you can see is looking down on that area, the body that's in place. You can see the opening for the spinal canal and cord. You can see these transverse costal facets where there's an intersection of how the rib connects in. And we're going to show you a picture of what that kind of looks like. And then the actual facets that connect to one another that form that armadillo type distribution. So let's say we take a quick drawing cartoon picture and we see how the rib connects in. Here you can see that vertebral body at the top. You can see the rib that comes along and it forms these points of connection, actually in a couple different spots. And these points of connection can have their own arthritis that's associated with it. So let me repeat that again. These points of connection can have its own arthritis that's associated with it. So you can have the facet arthritis in the thoracic region. And you can have where the ribs connect that actually can have some degree of arthritis as well. And that's one of the things that makes the thoracic region incredibly challenging, difficult to assess, and even more difficult to really kind of figure out where is this pain coming from, right? So when we take a look, normally we can say, oh, okay, well, there's a few different things. But here you can see that there's ligaments that tie the ribs in to the thoracic region, and just this whole gobbledygook mess of stuff, right? So how do we make heads and sense of this? Well, clearly there's been study of this for years, for centuries, and they've assessed different ways to be able to figure out where the pain may come from, where sensation comes from in the thoracic region. So when we look at that, it looks like the following. So what you can see initially is what is a dermal-tomal distribution. And so what does dermal-tomal distribution mean? It means the areas that are related to the nerve where you feel sensation and sometimes pain. So what you're looking at right now is a picture of someone from an anterior, meaning the front, their chest and abdomen. You can see the umbilicus or belly button down here. You can see these bands that say T3, T4, T5, T6, and so forth and so on. So what does that mean? It means the nerve that's associated with that thoracic level actually provides sensation for that region. And so when you have that sensation or you have a nerve that's impaired, you may have pain that's represented in that area. So then people would say, okay, that's pretty easy then. So if it's just a nerve, then yeah, there's no rhyme or reason with, having this be overly complex. Well, no, not quite. So if we're going to take a look, that thoracic region is actually varied in nature. The dermatomal distribution wraps all the way around the body. You can see that there's this other area that actually does have a bit of supply into the arm, surprisingly enough, which most people think the cervical region or the neck is what controls the arm in its entirety, but that's not quite true and accurate. Actually, there's a portion of the thoracic region that controls a portion of the arm as well. And more importantly, there is a degree of complexity which is greater than just the nerve root alone. And the reason why we started with the facet is it has its own distribution of referred pain. So don't get lost. Stick with me. If you have questions, by the way, ask them in the chat. I'll be happy to answer those of you who are joining us on the live stream. Those of you who are watching us later, this is the reason why to join the live stream, because you can ask your questions and get them answered real time. But if we're to take a look at what the facet referred pain looks like, it looks like the following. So normally you have this distribution that looks like, oh, T3-4 here is T4-5, T5-6. It all kind of fits in this orderly fashion. If you could probably gather from my tone and the sarcasm that's in my voice, what you can be able to know is that that's not the case. It actually looks more like the following, where you have this intermingling of things on top of each other, where 3-4 overlaps 5-6, which overlaps 4-5 and 6-7 and 7-8, and just this whole mixture, right, of things. So what most people would say, well, isn't it like that for all the rest of the spine where it's all kind of mixed together? Not really. If you look at the cervical spine, it looks like this. You can see C2-3, you can see C3-4, you can see 4-5, 5-6, 6-7. And those of you who are astute, you're like, well, it looks like the cervical region gets into the thoracic region. And you'd be right. So that's one of the things that makes the thoracic region even more complex, is because sometimes when you feel pain, it may not be coming from the mid-back alone. It may be coming from the neck. And there's this interplay of how the facets refer pain. And a good portion of them refer pain to the thoracic region. So what is there to be able to be done about this, right? When you take a look in the neck, you can see that there's clearly defined nerves that are associated with certain joints. And you have, for the most part, an understanding of where those nerves are that supply the facet joint, not the areas of the arm, not going into the brachial plexus, but supply the joint. And for those of you who follow our channel, you know there's a way to be able to try and treat that. There's actually numerous ways. And unfortunately, most of the time in medicine, there's traditionally two options that are mentioned. One is medication. Two is a procedure, and a procedure or surgery. And that's it. But quite frankly, there's a whole gamut of different procedures that exist that can be able to treat that joint pain that's present, whether it's in the neck, whether it's in the thoracic region, or whether it's in the lumbar region, and not just rely upon, quote unquote, burning the nerves. It's one of the videos that we have on our YouTube channel that talks about burning the nerves and what it feels, and is it truly really burning the nerves? But we won't go into too much depth and detail with that right now. But just know that there's more things to do besides heat, stun, or burn the nerves. There's other things that can be done using potentially orthobiologics like regenerative medicine to try to improve that, to be able to look at neuromodulation, both in the percutaneous as well as in the neuraxial region, meaning inside the epidural region as the latter, or the former being placing it within the periphery close to the nerve itself. And there are ways to be able to make those nerve sensations not quite as prominent, whether we're talking about radicular, like dermatomal distribution, or whether we're talking about oriented with facet. So when we talk about the neck pain normally, or the lumbar pain, we can say, okay, well, we know that there are nerves that exist. And although this looks complicated, we know where they sit. And so what we can do is to use that quote unquote facet joint injection or burning of the nerves at the site. So, in the cervical region, yeah, you place a needle down there, you kind of get an idea, you target it, and bada bing, bada boom, things are better. Is that the case in the mid back? I would guess if you guys were betting money, you'd be like, no. And you would be right. So in the thoracic region, it's different. It looks like the following. So although it seems like these little kind of stick figures sit pretty much in order, as you start going further down from T3 to T5 to T6 to T7, you can see they move off of the bony structure and they move away. And so when you start going to T8 and T9, the nerves that normally would sit in one position don't sit there. And then when you come back down into 12 and L1, they come back down and are closely associated with the bone. Why does all this matter? Because at the end of the day, you're trying to figure out how to be able to treat pain, how to be able to feel better. And so to know that, you got to know if you treat the thoracic region with local anesthetic, with steroid, with heat, will you get a response? And that's what one of the papers looks at. Diagnostic accuracy of thoracic facet joint nerve blocks, an update on the assessment of evidence. And so this was published in Pain Physician nearly 10 years or so ago. It's basically a treatise that talks about if you were to place a needle at that facet joint and try and target that nerve root, do you get a response? They looked at kind of a compilation of a number of different studies where you could see at one study that looked at 500 patients, another study that looked at somewhere around 50, and another study that looked at somewhere around 46 or so. At the end of the day, the conclusion was the following. What they were able to find was this, is that based on the review, they were able to show that the efficacy of and accuracy of thoracic facet joint injections were pretty darn good. Okay. So we know that being able to use radiofrequency can be able to provide some value. The downside, as we've discussed in other videos, is sometimes that could potentially cause problems with musculature that's associated with the joint. So things like the multifidus and other spinal muscles have dependencies upon those nerve roots that we're ablating or trying to ablate by applying heat there. And so that can result in some degree of muscle weakness, which can be a problem when you don't have the structure to be able to support it. In the thoracic region, you have increased structure and support from kind of that element of how the facet sits in terms of the different orientation. And you also have the ribs that provide some degree of support. But still, nonetheless, you don't want to just make an attempt at trying to treat the joint and you end up causing problems with muscle that ends up causing you other problems and issues. So there may be more elegant ways. One of those elegant ways includes the following, which is you reading the fancy term, but knowing that we're going to explain this. So don't let the title make you all nervous. At the end of the day, what we're going to do is, as we always say, we're going to explain it to you like you're 5 and that we're talking regular talk. So the title says peripherally induced reconditioning of the central nervous system, a proposed mechanistic theory for sustained relief of chronic pain with percutaneous peripheral nerve stimulation. Yeah. So fancy title, which basically is saying a way to be able to take a type of electrical lead that's small, that's thin, place it in close association to the nerve that's responsible for the joints and try to make that nerve calm. The upside behind this particular technology is that it is temporary, meaning you don't have to have an implantable device that stays in your bag permanently. It's able to provide sustained relief after the lead is removed. What do you mean lead? What are we talking about, Doc? So this is what we're talking about. We're talking about a lead that in essence is about 0.2 millimeters for its coil, or overall in terms of its overall size, and diameter is about 1 millimeter, which is incredibly small. And that can be able to provide a fair amount of relief by using that technique that I just described. How much so? So much so that they've seen in studies that there's a comparison when you look at the blue bar, which is this type of treatment, that's the temporary PNS, versus the yellow bar, which is a traditional treatment of radiofrequency ablation, that most patients were choosing peripheral nerve stim over radiofrequency ablation. And certainly we're choosing it over a permanent implant by a fair margin. And it was statistically significant. That's what that little asterisk means there. So what are some of the other advantages of doing a treatment like this? Well, some of the other advantages are the following, is when they take a look, by the way, it's pushed forth by Sprint PNS Therapeutics, so SPR Therapeutics. You can see that there's decreased risk. It's not as risky as opioids. It's not as risky as a permanent implant. And it has improved efficacy compared to just steroid injections alone or ablation. Now, do I think that there are other things that mimic or rival its efficacy? I do. I think there's some other things that probably are equally as efficacious, but it's one of the things that is probably very seldom spoken of. When you go to your primary care physician and ask them, how can I be able to improve this pain that's in between my shoulder blades? And they say, well, let's do some steroids and then let's send you to a pain doc and maybe they do a radiofrequency ablation. This is another alternative. And at the end of the day, one of the things that we want to do is to make sure that you understand your alternatives, understand your options, and are empowered so that you can be able to have a more robust discussion about how to be able to take your own healthcare within your hands and have a better outcome than what you otherwise might have. So what else can this do? When you take a look at the percutaneous PNS, 91% of patients had it placed on both sides. And traditionally, the lower back were the areas that were being able to be treated, but it actually can be used throughout multiple different parts of the body. Okay, so what about surgery? Is there a way to be able to treat thoracic region using surgery? It's interesting. I was actually at a conference just this past weekend with a mixture of surgeons in attendance, and there was brought up this conversation about the thoracic region. And without denigrating surgical colleagues, they really kind of basically poo-pooed and sort of laughed that the thoracic region doesn't really have pain. And they're full of malarkey, right? Because we see tons of patients that have pain in the mid-back for a number of different reasons. And it's not psychological. It has substance. And one of the reasons why we know is because we can do diagnostic blockade and get relief. One of the other reasons why we know is because we can be able to find anatomic and radiographic evidence of those problems. The question is how do we intervene? And surgically, it is incredibly difficult to intervene in the thoracic region. One of the main reasons why is because the lungs sit in close approximation to the ribs. And so now if you're talking about doing surgery, you really have to consider whether you want to deal with the lungs in some form or fashion. There are ways to deal with it based off of approach, meaning you have various different cannula and insertions that avoid it based off of the angle. There are ways to be able to put down a double lumen tube or a pulmonary blocker that stops the lung from inflating for a period of time. But that's a pretty extreme type treatment option. But there are other treatment options that are out there that can be able to provide some degree of value. We take a look at what happens with some surgical interventions in the thoracic region. Let's kind of talk about this. So this paper was published in the Asian Spine Journal, which mentions facet joint violation by a thoracolumbar percutaneous pedicle screw and its effect on progression of facet joint arthritis. Right. So what does that mean in English? What that means in English is that there was a traditional injection into the area. And that injection then was followed by a pedicle screw, which is a traditional way of being able to provide stability. That screw that normally is attached to be able to provide some degree of form or fusion, what they found is that it can cause a lot of different challenges and problems. And what the results of this were that for most issues, they had facet violations in about 6%, which isn't that much. But if you're part of that 6%, of the 1,000 some odd facets that were treated, it can be incredibly challenging. And 48 or nearly 50% of cases that had that screw basically not go where it should go caused and resulted in some degree of arthritis. And so treating it surgically in the thoracic region, really, just to kind of be fancy for a second, isn't the most elegant solution. However, there are new therapies that sit within the context of pain and surgery that are a minimally invasive approach that are looking incredibly promising. And one of those is one that we're going to talk about in a separate topic in the future. But just to kind of whet your appetite and kind of tease you guys just a little bit, it's actually something like the following. And that is the ion screw that's being manufactured by a company that is incredibly intriguing and interesting. And one of the things that you can see is when you talk about how does this look differently? Well, it's small enough to fit within the facet joints. And so if you were to take a look at traditional type screws, they look like this, right? Where you got stuff going all over the place. And now, mind you, that's not the way most screws are. They're actually a little bit more organized than that, but they're still fairly sizable. Versus this implant that I just showed you, it looks kind of like the following: much smaller, much more minimally invasive, much more muscle sparing, and provides a degree of improvement. Now, I have people that sit in the regenerative medicine camp that would say, well, it's a foreign device. It causes problems with biomechanical emotions. It can cause some other challenges and issues, and we shouldn't be fusing areas that we shouldn't fuse. And I think that, to me, when we take a look at how do we treat both function as well as pain, there's a gamut and there's a spectrum that exists. And anyone that tells you they can solve all their problems with one tool, I don't think that that's really accurate. And we could probably use some different adages for those individuals. I think reasonably, we need to understand, one, how severe the problem happens to be. And it may be that a minimally invasive approach will not work, and it requires a true traditional surgical intervention. On the other hand, it may be that surgery is not the answer in the greatest number of cases, and you can do something that may not even require a minimally invasive approach. You can do something that fits with the natural tendencies of the body by saying, okay, let's use the elements of orthobiologics, use platelets, that use stem cells, that use a way for the body to be able to heal itself. And then there comes the context of do we need to be able to utilize something in between or in combination? And I think that's where sensible medicine really kind of finds its roots, is how can we be able to give the patient the best function, decrease pain and suffering, as well as intervene, but intervene in a way that is judicious, that makes sense, and lets that person be able to get back on their feet quicker and do the things that they want to be able to do. So this talk today has been about the thoracic region and how that mid-back is completely different from the low back and the cervical region. We were able to kind of tell you how the nerves sit differently, how the facets are a different orientation, how the nerves that are related to the facets are completely different than other regions. And that requires a different frame of thought. It requires a different way to be able to kind of treat it. And it requires you to understand that you have options and to know that there is a way to be able to punch pain in the face and get back to leading the life that you deserve. Thank you so much for your time. Thank you for joining us. And please share this with someone who might need this. Have a great day.